Hi, good evening. We will be discussing the thyroid gland histology. The objectives for the lecture are for you to gain or to have at least a review of what you know about the gross anatomy of the thyroid gland, to have a bit of a background on its embryonic development, and to have a thorough understanding of the histology of the thyroid gland. The thyroid gland is the largest of the endocrine organs, and it weighs about 25 to 40 grams. It is an unpaired gland that lies on the anterior aspect of the neck, joined midline by an isthmus, and is slightly larger in women. The isthmus is like a bridge, no, that connects the right and left lobes of the thyroid gland. It adheres to the lateral aspect of the pharynx, larynx, esophagus, and trachea, and lies opposite to the cervical 5 to thoracic 1 vertebrae. And its inferior borders are at the level of the sixth tracheal cartilage. No? So take note of the relationship of the thyroid gland with the structures that are located anteriorly, posteriorly, in the midline, no, medially, no, and laterally, no, like in the anterior aspects, no, the infrahyoid muscles, right? The sternothyroid, superior belly of the omohyoid, sternohyoid muscles, no, laterally, the carotid sheaths, no, containing the common carotid arteries, medially, the organs that include the larynx, pharynx, trachea, and esophagus, no, and also the nerves that include the external and recurrent laryngeal nerves, no. So very important also for the thyroid, although that is not within the scope of this lecture, no, are the blood vessel supply, no. You have the superior thyroid artery, no, here, no, from the external carotid artery. You have the internal thyroid inferior thyroid artery, no, from the thyrocervical trunk, no, of the right and left subclavian arteries. And in some individuals, no, you have this accessory blood supply, the thyroidea ema artery, no, which comes from the brachiocephalic trunk, from the arch of the aorta. So try to be familiar with the anatomy, no, as well as physiology. I know you have discussions and lectures on this, as well as the histology of the thyroid gland as well. So, the development of the thyroid embryologically is quite complex. It originates from the foregut endoderm near the base of the developing tongue. Okay, that's why you have your foramen cecum there, no, towards the posterior aspect of the tongue, which is a depression where the thyroid once was during embryonic life. The endodermal tissue was derived from the floor of the pharynx for the main gland, and for your parafollicular cells, no, or your C cells, no, or the calcitonin producing cells, it is derived from the neural crest cells, no, because they are closely related, no, to neural tissue, and you will be discussing that later on in terms of the function of the C cells that produce calcitonin. Okay, so important to note, no, that from the base of the tongue, no, all the way to the anterior neck, the thyroid gland during embryonic development actually descends. Okay, it starts to descend in the anterior of the pharyngeal gut as a bilobed diverticulum, and during descent, it maintains the connection to the tongue via a narrow canal. No, you have the thyroglossal duct, no, that should eventually involute, no, or close. The descent is guided by a fibrous cord, no, called the tractus thyroglossus, no, or the thyroglossal tract. Okay, so that is a fibrous cord that guides, no, the descent of the thyroid. That's why, no, in some individuals, uh, from the base of the tongue, no? Since it descends, sometimes you will have remnants of the thyroid gland, no, from when it descended during embryonic life, no. So, however, ideally, no, walang remnants. And if you have remaining wala na involute, no, na thyroglossal duct, you can have an accumulation of fluid there, and that is what you call the thyroglossal duct cyst. No, sometimes when you go to your surgery rotation in your third year and in your fourth year, you will assist, no, in the closure of that patent thyroglossal duct that should not be there in the first place already, no, because it can accumulate, no, infections because it should have involuted already. So from the posterior aspect, no, of the tongue, which involutes as a foramen cecum, the thyroid gland in adult life should be within the anterior neck already. Yan. As the diverticulum descended, it bifurcated to form the two lobes of the thyroid gland. And by the seventh week of embryonic development, it reaches its final position in the anterior aspect of the neck. Yan. So again, no, the foramen cecum uh, in the posterior aspect of the tongue, no, is the remnant of where the embryonic thyroid once was. And if the remnant of the thyroglossal duct is still patent there, there can be an accumulation of fluid. So you call that a thyroglossal duct cyst. No? Yan. And that is why for anterior neck masses, you have to observe if there is movement on deglutition or swallowing, no? As that physical finding allows you to know whether it is related to the thyroglossal duct, no? Especially in children, if it moves, no? Kasi there is a connection with the posterior aspect of the tongue. Okay? Fistula, no, is an abnormal connection, no? So the fistula can be there if there is no involution, no, or no eventual destruction. And if there is a fistula, you can have an accumulation of fluid there that can be infected, okay, as a thyroglossal duct cyst. Okay, let's move on to thyroid hormone regulation. I know that you've had lectures on this and you've also discussed this in your small group discussion. It's important for you to understand how thyroid hormone is being produced so that you can understand the clinical correlates of the disorders of the thyroid gland. First, we go to the hypothalamus, no, within the brain. The hypothalamus, specifically the paraventricular nuclei, release your thyrotropin releasing hormone, no? Thyrotropin releasing hormone passes through the hypothalamic hypophyseal portal system, no, which is a network of capillaries from the hypothalamus and into the pituitary gland or the hypophysis, okay? Specifically the anterior pituitary gland, no, the anterior hypophysis, which is a true endocrine gland, okay? Because it produces thyroid stimulating hormone, no? It is a ductless structure, releasing it directly within to the bloodstream, no? And it travels, no, a far location through the bloodstream into the thyroid gland, which is also, no, as we know, the largest endocrine organ. So thyroid stimulating hormone will influence the thyroid gland to produce triiodothyronine and thyroxine T3 and T4. Okay? And these thyroid hormones eventually will reach the target tissues, no, for their various functions that include the regulation of the metabolic rate, specifically to increase the rate of metabolism, no, to increase the adrenergic receptors, no, to be more able to respond, no, to epinephrine, norepinephrine, no. So that's why if you have excess thyroid hormone, patients are shaky and nervous, no, because they have excess adrenergic receptors. Okay, and also to regulate core body temperature, no, as you will see later on, thyroid hormones will bind to nuclear receptors within the cells of the body to have the transcription, no, of RNA that regulates the enzymes within the cells, no, the sodium potassium ATPase, the enzymes related to the metabolism, no, of glucose and other nutrients of the body to increase the metabolic rate. So weight regulation is also influenced by thyroid hormones. Okay, so from the hypothalamus, TRH, to the anterior pituitary gland or the anterior hypophysis, TSH is being produced there, and into the thyroid gland where you have T3 and T4 production towards all of the target tissues for the body's metabolic rate. Okay, so as I have mentioned, the paraventricular uh, nucleus, which is a accumulation of neurons within the brain, release, releases TRH, okay, into the anterior hypophysis, no, or the anterior pituitary gland to release thyroid stimulating hormone, and thyroid stimulating hormone goes into the thyroid gland, influencing, no, or increasing the production of T3 and T4, eventually going to the target tissues. Very important is that you have feedback mechanisms, no. uh, if you have excess in thyroid hormone, that goes into the pituitary gland, no, decreasing the production of thyroid stimulating hormone, and the excess thyroid hormones will also influence the paraventricular nucleus of the hypothalamus to reduce the production of TRH as well. No? So you have these feedback loops so that the body will not produce excess hormones. Okay? Very clear here, as we have mentioned, no? These are board favorite questions. The anterior hypophysis or the anterior pituitary gland is actually a true endocrine organ. Okay? It releases its hormones through a ductless system, no, and through the blood vessel rich vasculature that is there, no, which is the hypothalamic hypophyseal portal system, no, that is rich in capillary beds there. Okay. However, the posterior hypophysis, on the other hand, is not a true endocrine organ. It is an extension, no, of the neural tissue, no, of the hypothalamus and brain. As you can see here, no, these are nerve fibers, okay? And the hypothalamus, as you know, of course, no, as it is a part of the brain, uh, they are collections, no, of these nuclei. Okay, so nuclei are collections of neurons within the brain. Okay, so you will discuss this later on, no, in your pituitary uh, discussions, no, that if you have adenomas here, no, or masses here that can compress on the other structures, specifically the optic chiasm, where the optic nerves, no, join and bifurcate into the optic tracts, no. So if you have masses in this location, the patient can manifest with some forms of blindness, specifically the bitemporal hemianopsia, bitemporal blindness. Okay, because you can have uh, mass effect on the optic chiasm, which is a part of the visual pathway of the brain. Okay, so within the pituitary gland, although we'll have another lecture on this, you have acidophilic cells, no, that like to take up the reddish pigments, no, unstaining on histological slides. You also have bluer or purpler staining basophils, and the chromophobes, no, which do not take up much of the stain. Okay, so these are histological preparations, class, no. So if they have to go through fixation, no, being immersed in formalin, no, if you have a specimen from biopsy or autopsy, and they will be processed, no, filled with paraffin wax, no, and then they will be cut, no, through an instrument called a microtome into very very thin slices, and they're being floated out, no, eventually placed into glass slides, and those glass slides, no, are being stained, no, addition of chemicals, no, and these are what we see under the microscope now, the acidophilic uh, cells no are redder staining, basophilic more bluish or purple in staining, whereas the chromophobes no in the pituitary gland here resist no taking up the dyes of the stain. Okay, so basically that's it no for the those structures of the pituitary gland. Okay, important to note no for the thyroid hormone regulation, your thyrotrophs are pale basophilic cells that produce thyroid stimulating hormone. As you can see here, growth hormone is also being produced by the anterior pituitary gland. Prolactin no, for milk production among new mothers no, after childbirth or even during the pregnancy no, is being produced by prolactin. No? Mostly acidophilic yan sila or orangophilic no, in some journals, some books. Corticotrophs, no, very important also for the production of cortisol. Melanocyte stimulating hormone also, no, are from basophilic cells, no, are being classified rather as basophilic cells. And no, follicle stimulating hormone for your testosterone in males, no, from the testes, and the estrogen, no, in females, no, from follicle stimulating hormone in the pituitary gland are also classified as basophilic cells. Okay? Luteinizing hormone also related to reproduction and fertility is also produced by these gonadotrophs, which are also classified as basophilic cells, more of purple staining or bluish staining. Yan. So you already know how thyroid hormones are being regulated from their neural to the pituitary structures that regulate it. Therefore, once you hear terms such as hypothyroid or hyperthyroid, you will understand what the origin of these lesions are. So, if you have primary hypo, meaning an underproduction of the thyroid hormones or the thyroid gland, this relates to primary failure of the thyroid gland itself. Okay? Such as in iodine deficiency, no, you need iodine to be able to produce your thyroid hormones. Secondary forms of hypothyroidism or underproduction of the thyroid hormones can be related to pituitary causes, whereas tertiary are related to lesions no or causes that affect the hypothalamus no. It can be a reduction of TRH that the hypothalamus should produce. So these are tertiary causes of hypothyroidism. So I know that you also have another discussion on thyroid physiology. However, no, this is just a review of what happens. You see here, no, the simple cuboidal cells of the thyroid follicle, no? So these are the main characters that produce your thyroid hormone. And within, no, this hollow structure of the follicle, you have the colloid where the T3 and T4 thyroid hormones are already located. Okay? What else is important here? So, you have several steps in the production of thyroid hormone. First is iodide trapping, no? So, iodide from the bloodstream, no? As the thyroid gland is a highly vascular organ, no? It has superior and inferior thyroid arteries, and in some individuals you have the thyroidema artery, right? You first undergo iodide trapping, no? So you need iodine in order to make your thyroid hormones, and it is being carried via the sodium iodide symporter, no? Whereby two substances are being brought within the cells through transport, okay? And then step 2 involves the synthesis of thyroglobulin, no? So globulin, this is a protein, no? So you know how proteins are being produced, right? There is a from transcription of the messenger RNA, there is translation of the protein. No? So you have that in the rough endoplasmic reticulum, right? You know this from your last module. Thyroglobulin is being produced and secreted. No? So this is the proteinaceous portion of the thyroid hormone. Okay. Step 3 involves the oxidation of iodide, no, and tyrosine iodination happens next. And then uh, once no you already have mono iodothyronine or diiodothyronine, you will have conjugation, no, or coupling, no, where you eventually have either T3 or T4 depending on the specific component that is being coupled or conjugated. Okay, and through a process of here, no, pinocytosis, no, or endocytosis, as pinocytosis is a type of endocytosis, you will have these vesicles that contain either T3 or T4 thyroid hormones. And once TSH stimulates the release of the thyroid hormone, it is being transported into the blood already. Okay, so that's basically a summary of the thyroid physiology. Yan. So you will see here within the cells, you have a thyroid hormone receptor within the nucleus of the cells, and with the help of retinoid receptor RXR, no, you have changes, no, in how the genes are being transcribed, no. So this influences, no, the production, no, of mRNA that will increase the sodium potassium pump, gluconeogenic enzymes, influencing the respiratory enzymes to be increased, no, increasing the beta adrenergic receptors to be more responsive, no, to norepinephrine and epinephrine, no, and this eventually, no, leads to the various effects of the thyroid hormone that involves the regulation of the metabolic rate, the regulation of the usage, no, of glucose and other nutrients, no, eventually helping in the regulation of body weight and also in the response to norepinephrine and epinephrine. Okay, so that's basically how the thyroid hormones will affect the various tissues and cells of the body. Yan. So the histology of the thyroid is actually very simple. The follicles are hollow structures that contain the colloid material, which is the proteinaceous thyroid hormone. Okay? And the follicular cells, no, are simple cuboidal cells. Simple cuboidal arrangement lang, no? So whereby you have this single layer of cuboidal, no, or square shaped cells, no, that enclose the follicle. Okay, so basically, the entire thyroid gland, no, aside from the septa and the connective tissue, is composed of these thyroid follicles that are simple cuboidal epithelium with colloid within, no, interspersed with parafollicular C cells, no, these paler staining cells that produce calcitonin, no, that is responsible for the decrease in calcium if calcium levels are already elevated. Okay, whereas the thyrocytes within the thyroid follicles produce T3 and T4 thyroid hormones. Okay, the central portion of the follicle, as we have mentioned, no, contains the colloid, the proteinaceous material, and T3 and T4 are produced by these thyrocytes here, the thyrocytes, which are simple cuboidal in arrangement. Okay, so when we say simple epithelium class, it means that it is only a single layer, whereas stratified, you have multiple layers of that specific cell type. Cuboidal cells, because they are square in shape, no? These are the nuclei. The total arrangement or morphology of the cell is that it is square. Whereas squamous, no? Those are flattened cells. Columnar are elongated cells, no, where the length is greater than the width. Cuboidal cells, no, the length and width are about the same. That's why they are square in shape. Yan, so you have these simple cuboidal arrangement with the colloid within the follicle. And these paler staining cells, you call them clear cells or parafollicular cells, and they are responsible for the production of calcitonin. On electron micrograph, you will see the thyroid follicular thyrocytes. Okay. Moving on, no? You also have another endocrine organ very, very close, no, or directly embedded within the thyroid gland, no? You have four parathyroid glands. Okay? These are small and ovoid, about 3 to 4 millimeters, with a total weight of zero point 0.4 grams. They are located no, uh, at the back of the thyroid glands and are embedded within the gland's capsule usually. And the microvasculature, the blood supply, arises from the inferior thyroid arteries. Okay? So, very, very important no, for the regulation of calcium, as parathyroid hormone goes no into the bones, no, influencing the resorption of bone, okay, increasing the levels of calcium. Okay, also important, if you have a thyroid tumor or a thyroid malignancy, and you need a total thyroidectomy, no, or complete removal of the entire thyroid gland. A potential complication is when even the parathyroid glands are being removed, no, so you will have hypocalcemia in that case, no. So it's very important that the surgeon tries to preserve the parathyroid glands as much as possible, if not retrieve them and implant them into another location so that calcium homeostasis still remains in that patient. Yan. So if blood calcium concentration drops, because calcium is important in the coagulation of the blood and in various enzymes and in various processes of the body, parathyroid hormone is being released by the four parathyroid glands that are located at the back of the thyroid glands. No, once PTH is being released, it goes into the bloodstream, of course, and eventually into the bone, influencing the resorption of the bone via these osteoclasts. So these are bone macrophage types of cells that will chip away, no, at certain aspects, no, of the bone, so that from hydroxyapatite crystals you have the release of calcium from the bone, eventually normalizing the level of calcium within the blood. Also, parathyroid hormones, no, will influence the kidneys to reabsorb more calcium from the urine and back into the blood. Okay. Also, uh, parathyroid hormone, no, and vitamin D uh, also will influence the absorption of calcium from the food into the gut, no, to the intestine, and eventually increasing the level of calcium within the bloodstream. If calcium levels are already at an elevated level, you have your clear cells, no, that produce calcitonin, and calcitonin will reduce the levels of calcium. Yan. So, the parathyroid glands are located within a thin capsule and with the septa extending into the gland with sparse reticular stroma that supports the dense elongated clusters of the secretory cells, no, the chief cells, no, are what produce the parathyroid hormones with supporting oxyphil cells. The parathyroid gland is derived from the pharyngeal pouches during embryonic life, the superior glands from the fourth pouch, whereas the inferior two are from the third pouches. Remember, you have four parathyroid glands. Yan. So you have these chief cells that produce parathyroid hormone, and we also have fatty adipose tissue there. Okay. So as we wind down, thankfully, we try to correlate our basic sciences with our clinical sciences. When you have Graves' disease, no, this is an autoimmune condition where the TSH, no, thyroid stimulating hormones within thyroid stimulating hormone receptors within the thyroid gland are being constantly activated by antibodies. Okay? So that is an abnormal stimulation to the thyroid gland. Therefore, you will have a diffuse enlargement, no, of the thyroid gland. Okay? And you also have overproduction of thyroid hormones. Okay? So remember, the thyroid follicle thyrocytes are supposed to be well arranged, no? But you can see, no, na overlap na yung mga cells, and there is overactivation, no? And there is also excess production, no, of the thyroid hormones within the follicles of the uh, cells and the follicles within the thyroid gland. Okay? So, Graves' disease, no, because there is excess thyroid hormone, even though the patients are constantly eating, they will lose weight, no, because the metabolic rate is very high. They can feel shaky and nervous because thyroid hormones will influence the beta adrenergic receptors. It increases, no, the susceptibility to epinephrine and norepinephrine, no? You can also have palpitations, no, because of the increase in beta adrenergic receptors, and also diarrhea and more frequent bowel movements because of the increase in the rate of gastric emptying, no, and the rate of the intestinal activity as well. Okay, so I just want to share of one of our patients in the past manifested, no, with diarrhea on examination. There was tachycardia and palpitations, no? And the protrusion of the eyeballs, no? Exophthalmos, no? Uh, which eventually we came to the diagnosis of Graves' disease in that patient, no? Na diarrhea lang yung concern niya at first, no? And actually, it was quite a severe case, no? So the patient was managed, no? With beta blockers, no, with fluids, no, to manage the diarrhea, with anti thyroid controlling medications also. Okay, you will see protrusion of the eyeball in Graves' disease because the autoantibodies, no, and the production of excess thyroid hormones will affect the extraocular muscles here. You have muscles there around your eye, no, that will push against it, and eventually it will bulge out of, no, the sockets and lids of the eyes, and that can even lead to blindness in very severe cases. Okay, so usually, as with most autoimmune diseases, no, your patient is a female. However, it can also occur in males. Hashimoto's thyroiditis, on the other hand, no, is also an autoimmune condition. However, you have the production of lymphocytes that will attack the thyroid follicles, the thyroid thyrocytes, no, and the structures of the thyroid gland. You can also have, no, goiter. Goiter is a generic term for the enlargement of the thyroid gland. However, it is hypothyroid, no, specifically primary hypothyroidism. So just the opposite of hyperthyroidism, no, a reduction in the metabolic rate, no. So you have insensitivity to the cold, cold intolerance because the metabolic rate is very low, decrease in the body temperature, and even if the appetite is already reduced, the patient will still have weight gain because the metabolic rate is very slow. You can also have reduction in the heart rate, bradycardia, and in very severe cases, no, you can even have impaired memory, no, or functioning of the brain. Also, patients can have constipation, brittle thin nails, no, and coarse brittle hair, no, as these are effects of normal thyroid hormones should be able to regulate this. However, in Hashimoto's thyroiditis, you have a destruction in the architecture, no, and the structures of the thyroid gland, because there is the intrusion of those lymphocytes, no, and antibodies that attack the thyroid structures. So histologically, no, you will have lymphoid structures, no, accumulation of lymphocytes within the thyroid gland parenchyma, no. So imbes na thyroid follicles lang, you have this accumulation of these lymphoid follicles that are accumulation of the lymphocytes, no, because there are self-reacting antigens there. Thus the body assumes, no, that there is a foreign invader within the thyroid gland. However, the body is attacking itself in Hashimoto's thyroiditis. Okay? Yan. Another is iodine deficiency hypothyroidism. Also hypothyroidism, so you'll have the symptoms of the reduction in the thyroid hormones. This is not very common nowadays, class, because our salt is being fortified with iodine, your iodized salt already, no? So quite rare na yung iodine deficiency. However, in some areas, rural, mountainous areas without sufficient sources of iodine, no, you can have iodine deficiency hypothyroidism. Although there is a reduction in the thyroid hormone, you will have an enlargement, no, or you can have an enlargement of the thyroid gland, which appears as a goiter. Okay, and usually landlocked areas, no, because iodine is usually seen in our fish, our seafood, and in our seaweed, no, among other sources. So usually rural landlocked areas that have no access to the sea or fish and seafood are being affected by iodine deficiency hypothyroidism. Yan. So on histological sectioning, instead of the cuboidal cells, there will be a flattening of the thyroid follicular thyrocytes there, no? And reduction in the thyroid hormones in the thyroid follicles as well, no? So instead of the very nice thyrocyte morphology that is cuboidal, you will see a flattening. And there is no thyroid hormone because functional thyroid hormone because iodine is deficient in these patients. Hypoparathyroidism happens when you have, usually, no, you will see this during cases of a patient who has undergone a total thyroidectomy. For example, during cases of thyroid cancer, where the surgeons have to remove the thyroid gland in its entirety. And you know that the four parathyroid glands are located at the back of the thyroid gland, usually within its capsule. So if the parathyroid glands are not preserved adequately, you will have a reduction in calcium serum, no, or circulating calcium. That's why when you tap, no, this portion at the side of the patient's face, no, you will have a spasm of the face, no, because of the irritability of the nerves there. You call that the Fostex sign. No, very important when you have a post thyroidectomy patient, when you reach your surgical rotations. And also, if you place a sphygmomanometer or your blood pressure cuff and you leave it there for a few minutes, if there is spasming, no, adduction of the thumb, flexion of the metacarpophalangeal joints, no, and flexion of the wrist, extension of the interphalangeal joints, no, itong sign na ito, you call this your Trousseau sign. Okay? So this also tells you that there is hypocalcemia. So very important that for those, no, who will be rotating in surgery, you will also assess your patients for the functioning of their parathyroid glands, no, that release parathyroid hormone that increase the circulating calcium within the blood. Yan. So in some patients, no, the surgeon will opt to implant the parathyroid gland in the forearm, no, to make sure that it is being preserved, no, You will have collateral circulation. No, eventually blood vessels will join with the parathyroid glands there, and it can still produce the parathyroid hormone. So in partial thyroidectomy, no, there will still be, of course, the parathyroid gland being left there. However, in total thyroidectomy, the surgeon has to be sure to preserve the parathyroid glands, no, if they are not being affected by the cancer or the disease, and also the vascular structures, and also no the nerves, especially the recurrent laryngeal nerve, no, and the other nerve structures that are there, no, for the patency of breathing. Okay, so you will learn more about that as you go on. In summary, the thyroid gland is the largest endocrine organ that lies in the anterior neck. The histology is highly characteristic. You have the simple cuboidal epithelium that surrounds the thyroid follicle that contains the colloid, that is the thyroid hormone being stored. Okay, so you have to understand how the thyroid gland develops, how it descends, what are the anatomic structures that it has, as well as the tissue morphology, no, microscopic morphology of the thyroid gland, as with all of your other organ systems, as well as the physiology, in order for you, no, to be able to better prevent, treat, and manage the various conditions that you will see in your clinics. Okay, I think that's basically it. Okay, so with that, thank you very much, and God bless everyone.